It's gonna move, so let's make a start. Hello everyone, welcome to our 7th online workshop. Today we're going to be talking about the development of an exon skipping therapy for Alport syndrome. Today we have one presenter who will be presenting his research and work to you. This talk should be extremely exciting because it is the first opportunity for many of us to have a look at some exciting new research that could point to a possible treatment for Alport syndrome. In other words, you're going to want to stay till the end. I just want to point out to our patients today to a very short document, which should help you get the most out of our workshop. The link to that document is in the chat now. Basically, it explains some of the basic theory behind Kandai's work, and it's very digestible, and it's important, I think, that you read it before we go to the presentation. It's very short. Let's begin with some introductions. Our speaker today is Kandai Nozu, the professor at the Department of Pediatrics in Kobe University Graduate School of Medicine in Japan. He will be sharing his research into the development of a novel gene targeting therapy for Alport syndrome. And we're very privileged to have him with us today. Furthermore, we're extremely lucky to have our scientific moderator who will be helping to put questions to our guest. Today, that's Danny Gale, an associate professor of nephrology at the Faculty of Medical Sciences at the Royal Free Hospital in London. Right, I think that's enough from me. I think it's about time I hand over to Kandai. Would you mind sharing your screen and taking us away?
Okay.
Okay, we can see your screen and we can hear you. So by all means, go for it.
Can you see my slides? I'm sorry, I can't hear you, Patrick.
We can, yeah, we can see it perfectly.
Okay, thank you so much. Thank you, Patrick, for your kind introduction. And I'm Kandai Nozu from Kobe University in Japan. First of all, I'd like to thank to the organizers and the audience for the opportunity of my today's talk. My today's topic is about the exon skipping therapy for Alport syndrome. Let me start my presentation. And this slide shows the topics of my today's talk. First, I'd like to talk from the basic knowledge about the Alport syndrome, clinical features, and the pathological findings of the Alport syndrome. Alport syndrome, I'm sorry, I have to show you the laser pointer. Alport syndrome encompasses a group of inherited heterogeneous disorders involving chronic kidney disease progressing to end-stage kidney disease, ESKD, sensory neural hearing loss, and ocular abnormalities, eye abnormalities. The various inheritance forms of the disease include the following of X-linked, autosomal recessive, and autosomal dominant. This slide shows the genetic background for Alport syndrome. About 80% of the patients are X-linked. The responsible gene is COL4A5, which encodes type 4 collagen R5 chain. This is the X-linked disease, and men have only one X chromosome and women have two X chromosomes. So men usually show the severer phenotype compared to female patients. This slide shows the kidney survival curve for male X-linked Alport syndrome patients in our Japanese cohort. In total, 422 patients were included in this study. The median age developing end-stage kidney disease, ESKD, was 35 years in our Japanese cohort. And this slide shows the pathological finding. With the electron microscopy, in normal, this is a glomerular basement membrane. Glomerular basement membrane shows the equal thickness and equal density like this. However, in Alport syndrome patient, glomerular basement membrane, this is a glomerular basement membrane, shows a very thick and irregular pattern, and inside is shows a splitting of the basement membrane. This finding is usually called as a lamination or basket weave change. And so with the type 4 collagen R5 chain expression analysis in normal kidney, both glomerular basement membrane and Bowman's capsule shows the alpha-5 expression is this green signal. However, in male X-linked Alport syndrome patients, because of the COL45 gene mutation, they can't produce alpha-5 chain, and as a result, both Bowman's capsule and glomerular basement membrane shows a negative alpha-5 expression. However, we have reported previously about 30% of the patients shows a positive expression of alpha-5, and they tended to show milder phenotype, later onset of ESKD. On the other hand, in female patients, females have two X chromosomes. It means patients have both wild type COL45 gene and mutant allele, and one cell will select only one allele by X chromosome inactivation. So each cell have only one allele activation. So if one cell selects a wild type COL45, this cell can produce alpha-5 chain. However, one cell selects a mutant allele, this cell can't produce alpha-5 chain. So in female patients' glomerulus, alpha-5 expresses random expression. This pattern is called as a mosaic pattern, like this. And next, I'd like to show the case presentation, the typical familial cases with X-linked Alport syndrome. The proband is here, and square means male, and circle means female, and the black means patients, and white means a healthy family member. And the case is a 33-year-old man. At the age of 2, he had detected the macrohematuria, bloody urine, when he has a viral infection. At the age of 6, he had a kidney biopsy and pathologically diagnosed with Alport syndrome. At the age of 17, he developed ESKD, and at the age of 18, he had kidney transplantation. The donor was his father. And his younger brother also developed ESKD at the age of 28. And their mother, grandmother, and great-grandmother had the urine abnormalities of urine protein and hematuria, but they didn't have the kidney dysfunction. So in this family, male patients had a much severer phenotype compared to female patients. This is the character of the X-linked Alport syndrome. And with the pathological finding, he had this is a glomerular basement membrane. He has a basket weave change here with a thickening, and the alpha-5 expression was completely negative. This green signal is an alpha-5 chain. So the patient didn't express the alpha-5 chain like this. And with the gene test, he had here, this is a patient test result. He has a C2T single base substitution here. And TAA encodes stop codon. Stop codon is encoded by TGA, TAG, or TAA. So if the patient have a single base substitution and makes this sequence, this is so-called nonsense mutation. So he was having the nonsense mutation in exon 45 of COL45 gene. Next, I'd like to talk about the genotype-phenotype correlation. This slide I showed you earlier. In our Japanese cohort, the median age developing ESKD was 35 years in male X-linked Alport syndrome patients. And we divided our patients into genotypes. And the nonsense mutation is a severely damaging gene mutation. And the missense mutation is a relatively mildly damaging gene mutation. And others are have a middle damage. And this black curve shows the patient's kidney survival curve, patients with nonsense mutation. The patient's number is 30. They develop ESKD at the median age of 18. This median age means that 50% of the patients develop ESKD at the age of 18, here 18. And the patients with missense mutation, the patient's number was 244. This yellow curve shows the patients with a missense mutation. They developed ESRD at the median age of 40. And other genotypes show the middle severity. So there was 22 years difference between patients having nonsense mutation and patients having missense mutation. So this means that this disease shows a very strong genotype-phenotype correlation. And then on the other hand, this graph shows the kidney survival curve for female X-linked Alport syndrome. The patient's number was 312, and they developed ESKD at the median age of 65. So female patients show the milder phenotype compared to the male patients. Next, I'd like to talk about the current treatment for Alport syndrome. As Professor Oliver Gross already reported, ACEI inhibitor or angiotensin receptor blocker works well for the treatment of the Alport syndrome patients. ACEI inhibitor or ARB is so-called RAS inhibitor. We divided our patients into patients treated by these drugs and patients without treated by these drugs. The patients without this treatment developed ESKD at the median age of 28 in our cohort, but the patients treated by these drugs have not reached 50% until 50 years of age, which means that these drugs work well and delays the development of ESKD for at least 22 years. However, when we divide patients into having truncating variants, severely damaging variants like nonsense mutation or non-truncating variants, these are mildly damaging variants, including missense mutation, and compare the treatment effect. Please see the red curve. Patients with non-truncating, mildly damaging mutation and without having the treatment by RAS inhibitor developed ESKD at the median age of 33. But the patients treated by these drugs having a non-truncating mutation and treated by these drugs have not reached 50% until 50 years of age, by far above 50%. So it means patients having non-truncating mutations, a RAS inhibitor works very well. On the other hand, patients having truncating mutation and without treatment by these drugs, this black curve shows that these patients developed ESKD at the median age of 16, very early. And patients having truncating mutations and treated by RAS inhibitor developed ESKD at the median age of 28, this green curve. So this treatment works well even for the patients having the truncating mutations, but still they develop very early. So we need to develop a new treatment for the patients having truncating mutations. Let me go back to the first familiar case. The elder brother developed ESKD at 17 years old, and he didn't have the treatment by RAS inhibitor. And the younger brother developed ESKD at the age of 28, and he was treated by RAS inhibitor. So RAS inhibitor, they are having the nonsense mutation, truncating mutation. And so RAS inhibitor works well and can delay the development of ESKD, but they still have a severe kidney disease. So we have to develop the new treatment for the patients having truncating mutations. We are developing exon skipping therapy. One patient reminded us to develop this treatment. This case was having the exon 27 skipping, and exon 27 is consisted by 105 base pair of nucleotide. This is a multiple of 3. I will explain this about this with the next slide. And had not developed ESKD until 46 years old. He didn't have the last treatment. So he showed the milder phenotype. On the other hand, one case had been reported from another country. He has a nonsense mutation in the same exon, exon 27, and developed ESKD at the age of 23. So both patients were having the mutation in the same exon, exon 27, but one case developed ESKD at the age of 23, and one case developed ESKD at the age of 46. What's the difference between these two patients? He was having the nonsense mutation. He was having the 105 base pair deletion. What's the difference? From messenger RNA, amino acid will be produced. This process is called as translation. At the process of translation, each 3 nucleotide encodes 1 amino acid, and these amino acids will produce a protein. In chlorofile gene will produce alpha 5 chain. So when patients were having deletions with the deleted nucleotide number was multiple of 3, for example 6 base pair, these 2 amino acids will be deleted here. But the following amino acid sequence will not be changed. So it means in our this patient were having the exon 27 skipping, 105 base pair skipping here. But following amino acid sequence will not be changed. So he has this, the end of the R5 chain. But the nonsense mutation will terminate the protein production at the nonsense variant. So this patient didn't have this part. Alpha 5 chain forms a triple helix with alpha 3 and alpha 4. And this part is called as a non-collagenous domain, NC domain. This NC domain is the most important point for the formation of tumor with alpha 3, alpha 4, alpha 5. And this part is also very important to form the tight network in the glomerular basement membrane. So NC domain is a very important part of the R5 chain. With the nonsense mutation, this R5 chain is terminated by here, and they don't have the NC domain here. But with the inflamed deletion, they have NC domain. COL45 gene is a very large gene. It has 51 exons. And first 2 exons and the last 4 exons are out of collagenous domain. So our target is in the exons in the collagenous domain. As you can see, these numbers are nucleotide numbers in each exon. So as you can see, numbers in black are the multiple of 3. So when the patients were having nonsense mutations in these exons, and we produce the exon skipping for the exon which has a nonsense mutation, we can replace the nonsense mutation into inflamed deletion mutation. And with this treatment, we can reproduce the NC domain by this exon skipping therapy. So theoretically, exon skipping treatment can lead the patients into milder phenotype in Alport syndrome. First, we conducted the computational analysis using the supercomputer. This figure shows a triple helix formation by alpha 3 and alpha 4 and alpha 5. The formation is very beautiful, like this. This is the NC domain. This NC domain is a cropped figure. Alpha 3 and alpha 4 and alpha 5 is forms the tumor, like this. But when we put the information of the nonsense mutation in exon 21 to this analysis result, this tumor formation is collapsed like this. This tumor doesn't work as a tumor. And when we put the information of the exon 21 skipping, again, this tumor can form very beautiful formation like this, almost the same with the wild type tumor formation. So when we replace the nonsense mutation into exon 21 skipping, we can reproduce the R5 tumor formation like this. Exon skipping is theoretically not difficult. All exons have an exonic splicing enhancer, and the SR protein will bind to here, and as a result, at the production of the messenger RNA, exon B will be included, like this. So when we block this exonic splicing enhancer region by antisense oligonucleotide, ASO, this will block the SR protein binding to ESE region. And as a result, exon B will be skipped by ASO. So this is theoretically easy. We first start to develop a drug for exon 21. Exon 21 has an 84 base pair. This is a multiple of 3. So first, we conducted the treatment to the cultured cells, and we treat these cells by ASO, antisense oligonucleotide, and 48 hours later, we extracted the messenger RNA and checked the exon skipping effect. 0 means no treatment, and 10 is a very low dose of drug treatment. And you can see without treatment, and this band shows a larger compared to the other bands. And this larger band was having the exon 21 because this is no treatment. On the other hand, and these treated cells shows a smaller band, and this smaller band had no exon 21. So these drugs can successfully produce exon 21 skipping here. So next, we established the mouse model, which have a nonsense mutation in exon 21. This mouse model shows a completely identical phenotype to the human Alport syndrome. And this is a serum creatine level. This mutant mouse shows a elevated creatine level, which means kidney dysfunction. And urine albumin excretion level increases like this. And they start to die from 26 weeks, like this, because of the kidney dysfunction. And with pathological finding, this mutant mouse doesn't show ALK5 expression like this, completely negative expression of ALK5. And glomerular basement membrane shows a splitting of the glomerular basement membrane, like here. So this mouse model shows that clinically and pathologically completely identical to the human Alport syndrome. So we started treatment to this Alport mouse model with an ASO. From week 4, we started the treatment subcutaneously under skin, injection under skin. And from week 4, twice a week until week 7, and from week 7, once a week until week 20. And at the week 21, we harvested the kidney. And this graph shows the body weight change. ASO means that Alport mouse treated by ASO, and vehicle means that Alport mice treated by placebo. And normal means a wild type healthy animal, a mouse model. And so And the body weight change shows no difference, which means that ASO didn't cause a severe side effect, including the appetite loss. Body weight gain was very well. So no severe side effect. And we extracted the messenger RNA from kidney, and wild type vehicle means a placebo-treated Alport mouse, and ASO means ASO-treated Alport mouse. And the messenger RNA shows a larger band in placebo-treated mouse and a smaller band in ASO-treated mouse. And this smaller band shows a complete exon 21 skipping. So exon 21 was successfully skipped by ASO treatment. And this graph shows the urine albumin level, urine protein level. Placebo-treated mouse shows the increase of the urine albumin. However, ASO-treated mouse shows the urine albumin level is very low, like this. And this graph shows the serum creatine level at the 21-week. Placebo-treated mouse shows the elevation of the serum creatinine compared to normal, which means that this mouse is having the kidney dysfunction. However, ASO-treated mouse remains the kidney function in normal range, like this, compared to the normal. And with a pathological finding, placebo-treated mouse shows a very serious damage in the kidney interstitial area. Blue means a fibrosis of the kidney interstitial area. So this mouse, placebo-treated mouse, had a very serious damage, and the glomerulus were also damaged like this. However, ASO-treated mouse shows no kidney interstitial fibrosis like this, very beautiful, and the glomerulus stayed intact like this. And with the electron microscope, this is a glomerular basement membrane in wild type mouse. And in placebo-treated mouse shows a serious damage on the glomerular basement membrane, very thick, like here. However, ASO-treated mouse shows almost a normal appearance, like this. And finally, this is a very exciting data. Wild type shows the alpha-5 expression on glomerular basement membrane and the tubular basement membrane with this green signal. And the placebo-treated mouse don't have the alpha-5 expression like this. However, ASO-treated mouse shows the alpha-5 expression, not completely expressed compared to the wild type, but they show the alpha-5 expression. Like this. And this graph shows a survival curve for mouse models. This curve shows a mice with a placebo-treated. They start to die from day 160, and at 180, more than 50% will die. However, mice treated by ASO, none of them died until day 180. So it means that ASO treatment worked very well. Let me summarize our result. By exon skipping therapy, this stop nonsense mutation will be replaced by inframe deletion mutation. And as a result, NC domain will be reconstructed by this treatment. And alpha-5 expresses on the glomerular basement membrane. And this will lead the clinical symptom very mild. Let me conclude with this slide. Male X-linked Alport syndrome patients show strong genotype-phenotype correlation. RAS inhibitors, ACEI inhibitors, and or angiotensin receptor blocker are effective for delaying the development of end-stage kidney disease in X-linked Alport syndrome patients. However, for severe patients with truncating mutations, the treatment is less effective. we are developing the exon skipping therapy for patients with truncating variants. This therapy gave a promising effect in the animal model. But our currently developing drug is only for exon 21. The patient number is quite limited. In Japan, we have only 2 patients. And currently, we are conducting the safety evaluation study. And after confirming the safety, we will planning to conduct the clinical trial for exon 21. And after we confirm the safety and effect of this therapy, we will brought the target to other exons of the COP45 gene. Okay, thank you so much. This is my boss, my Professor Kazumoto Iijima. He always gives us good suggestions and good advice. And this is Dr. Tomohiko Yamamura. He did most of the experiment he did. And he got the Cecil Alport Award at the last International Alport Syndrome workshop in Siena. I'm sorry. Thank you so much for your attention. And I'm happy to take questions.
Well, thank you much. Thank you very much, Kandai. That was absolutely incredible. And unlike a lot of our speakers, I think you've actually very well managed to explain the basics behind Alport syndrome. So thank you very much for that. I was kind of blown away that the sort of inspiration for this whole thing came from one particular patient, and that then led to a bunch more research. So my first question really would be what sort of stage were you finding, and maybe you mentioned this in the presentation, what sort of stage were you finding that this sort of treatment was effective? Because I think for humans, they would consider that they already have symptoms. Would it be effective on late stage kidney disease, for example?
Okay, thank you for the good question. Maybe we are not sure, but because we have not started the clinical trial, but I think we believe that this treatment is effective for the patients not having the kidney dysfunction. So early stages with the urea abnormality, but the creatine, serum creatine level is not elevated. We believe this treatment works well.
So in other words, it's not going to restore lost kidney function in a sense.
Yeah.
Okay.
That's right.
In the mouse models, were you controlling for sex as well? I know you mentioned that there were differences between how female and males presented with the disease.
Therapy only for the male mice models, only for male.
Okay, cool. We had a very interesting question from someone that was asking you to speculate a little bit on the impact of this treatment on the other symptoms of Alport syndrome. So we've seen its possible implications for ESKD, but what about hearing and eyes?
Okay. Yeah, that's also a very good question. And we conducted the examination whether our drug will be distributed to the kidney. And it was very large amount of drug were distributed to kidney, because this drug will be excreted from kidney. So kidney is the most important target for this treatment. But if this treatment, this drug will be reached to the inner ear, this treatment will work well for the hearing loss. But I'm sorry, we have not performed the examination for the distribution of the drug to the inner ear or not. But this is also a very important point.
Sure, I think people would be fascinated to see future trials and see how that what sort of impact we might see there. And this is another very basic question, so you have to forgive me. To what extent do these results in mice give you confidence for human trials? you said, I think a quote from the presentation was that mice were clinically and pathologically identical to humans. What sort of application might this drug have in human patients? Obviously, you haven't done trials yet.
So, I'm sorry, would you give me, would you rephrase your question?
No, it's fine. Would this treatment be possible to use in human patients at some point? What's the time frame for future trials on human patients?
So now we are conducting the safety evaluation trial for using the animal model, for example, a monkey and mouse, and we are evaluating the safety. And after confirming the safety, we can move on to the clinical trial. So I think near future, in a couple of years, we can start the clinical trial.
And then my final question, really, I think patients are always concerned with the way that these drugs are applied. Is the ASO injected, or what's the method of delivery to the kidney?
Okay. For the animal model, we conducted the injection subcutaneously under skin. And this antisense drug treatment is already applied to the Duchenne muscular dystrophy, completely different inherited disease. And for this treatment, drug were injected intravenously. So I think both works well, intravenously or subcutaneously. Both works well. But now we are adjusting the dose for the treatment, and we believe this treatment is applied once a month or once every 2 weeks or something.
I think that's good news for patients for sure, because of course the question would be if it has to be applied daily and it's an IV thing, then it's not useful.
It's very hard.
Okay, I'm going to go for it.
Oh, okay. We tried one injection and harvested the kidney 1 month, 14 days later, 2 weeks later, and the drug was still in the kidney. So we confirmed that drug treatment works at least 2 weeks. So we think this drug works, one injection works for more than 2 weeks, maybe 1 month.
Okay, well, that's good news for patients. Thank you so much, Kandai. I'm going to hand over to Danny now, who I'm sure has got a bunch of questions from our Q&A panel, as well as his own thoughts.
Yeah, thank you. Thanks very much for a really interesting and positive presentation. It's very exciting data and inspiring, I think, to lots of people, judging by the questions that have come through. Some of the questions were sort of overlapping and cover a number of different areas. One of the things that came through was questions about the types of mutations.
I'm sorry, I can't hear you. I'm sorry, I couldn't hear you.
Okay, one of the questions relates to the type of mutations. So you mentioned the effect on premature stop codons, but do you think there might be a role for exon skipping of exons that contain a missense variant or a small deletion or another frame shift or something like that?
Okay, that's a very good question. Our treatment is applied to the all truncating variants. So missense variants usually shows the milder phenotype, but truncating means a nonsense, small deletions, which deleted nuclear number is not multiple of 3. For example, 1 deletion, 1 base pair deletion or 2 base pair deletion. This is a truncating variants. So we can apply this treatment for all truncating variants, all variants with showing the severe phenotype. But this treatment can be applied for only exons which exon nucleotide number is multiple of 3.
Okay. And do you think of all the exons that have multiples of 3, do you think they are all equal? In other words, some of your earlier clinical data showed that the outcomes from people with small deletions or in-frame deletions was was more similar to people with truncating mutations. So do you think replacing a truncating mutation with a small deletion would be effective in all of the exons, or is it something special about this exon?
Yeah, I think so. I think so. For all truncating mutations, exon skipping can replace a mutation in truncating mutation into inflamed deletion. So theoretically, all truncating mutations are our treatment target.
Okay. And how long does an exon-specific ASO need to be to prevent incidental suppression of off-target exons? So to get specificity, how large does the ASO have to be?
How large means how many ASOs?
How many nucleotides?
In the ASO?
Yeah.
Yeah, about 15.
Okay.
15 nucleotides it has in the ASO.
Okay. What do you think the main obstacles are going to be to get this through clinical trials and to be a treatment for patients?
I'm sorry, can you rephrase it?
What do you think are going to be the hardest barriers to getting this to the clinic?
Okay. So there's a big problem because as I mentioned, in Japan, truncating variants in exon 21 is very rare. So we have only 2 patients, and for developing one drug needs a very huge money to conduct the clinical trial. And at first, we believed that after developing one ASO for one exon, other drugs will be automatically approved by FDA or PMDA in Japan, but it was not true. We have to develop all drugs for each exon one by one, so it needs a huge money. So now we are currently developing the drug for exon 21, and then we are having the support from the Japanese government for exon 21, but I don't think for other exons we can have the support from Japanese government. So we need the partner of the pharmaceutical company.
I see. Okay. And what proportion of patients with Alport syndrome have truncating mutation?
Okay. That is also a very good question. About 15% in our cohort. But as you know, there are no hot mutational spot. So all patients with truncating mutation having the mutation in different exons.
Okay, fine. I hope I've covered most of the questions that people have asked. Thank you very much for your comprehensive answers to them.
Mm-hmm.
Oh, there was one more question.
Oh, go for it, Danny.
Which sort of relates to how late on in life might institution of this therapy be effective. So if you take somebody who's already got established kidney damage, who might be older, how advanced do you think it would need to be to be amenable to this treatment?
I think after starting the kidney fibrosis in the interstitial area, our treatment doesn't work. So before starting the kidney interstitial fibrosis, our treatment can work well. So it might mean that before starting the kidney dysfunction, before starting the elevation of the serum creatinine.
Right. Okay. I understand. Well, thank you very much.
Thank you.
Okay. Amazing. Thank you. Okay. Brilliant. Our final piece of feedback, as always, this has not worked for the last 2 times we've done it, but we're optimistic it's going to turn out this week. We're going to try and conclude with a word cloud. So there should be a link in chat now from Archie Walker. All you have to do is click on that word cloud and put in the panel just a few words about how you feel having watched this webinar today. And I'll even submit as well. Very excited, lovely. Interested, hopeful. Once you've submitted your words, you can come back to the Zoom screen and you'll see the word cloud popping up in front of you. More questions, inspired. Great to hear genetic dev. Excited. Lot of hopeful. Well, fantastic. And I'm glad it's worked as well. So we're going to leave that up for a few seconds. I just want to thank everyone for coming today. It's great to see so many people engaged with pretty cutting edge research. I think as drug companies and researchers look at these workshops, as we know they're doing, it's going to be very, very good for them to see that this community is excited and informed about their condition. So with that, I want to thank Kandai for sharing his fascinating research with us. It's a real privilege to have this relationship with our researchers. And of course, thank you to Danny for putting all of those questions to him. I think we had a phenomenal number. Cheers to Kidney Research UK for their sponsorship. They help fund our Zoom subscription and, of course, keeping the lights on at Alport UK. Before you go, I want to remind you of our workshop next week. Next Wednesday, we have a workshop at the new time of 9:30 a.m. BST. So that's in the morning. And that will be on eye abnormalities with our presenters from Australia, Judy Savage and Debs Colville. We haven't covered the eyes much in detail yet, so it should be great to have a bit of focus on them. If you have any more feedback about this session or want to be added to our mailing list, email research@alport.info. And we should have pasted that email in chat now. Please do follow us on social media as well to hear updates about our workshops as they happen and details about upcoming research and physical workshops, God forbid. Patients can join the Alport's Warriors Facebook group to get help and meet other people with their condition. And anyone can hit us up at our Twitter page. That's at Alport UK. Okay, thank you to everyone for helping me out. Thank you to Harriet and Archie for working behind the scenes. Thank you to Danny for putting all the questions. For those of you that would like a recording of this talk, we're going to be popping it on YouTube and our Facebook page sometime this week. For now, all that remains for me to do is thank you all very much for watching, and I want to wish you a great rest of the week. Bye-bye.